Please go ahead and start.
Hi, did the video actually play?
Oh, it played on my side. Didn't you get it?
No. Mzamo, did you get it?
No, I also didn't see it. I just saw the advert screen.
Okay. Oh, you saw the advert at least, so that worked.
We saw Project Echo, G Echo. That's all we seeing a screen that says Project Echo, G Echo.
Okay, well, there's the advert again. We'll play the video next time. I'm going to stop the share and then you can take over, VG. Thank you.
Thanks, Karen. Welcome, everybody. Find this thing. Okay. Welcome evening to all who have joined after a long weekend. I'd like to say welcome to Echo, which is hosted by the Gastro Foundation in association with Project Echo, University of New Mexico. The Echo Fellows is run every second Monday at 6 o'clock in the evening. If you have any questions, the chat is open. So I think our presenter this evening is Mzamo Mbelle. He's one of the GI fellows, and Mzamo, I think we may as well start. We're already a few minutes after 6 o'clock, and hopefully a few others may log in a bit later on. But just before you start, Professor Sechedi just sent a apology that she's on a call, and also that she does understand that we're having this meeting straight after our fellows weekend, and it is exams for some of our fellows tomorrow. So that's from Professor Sechedi. Okay, Mzamo, I think you're going to speak to us on something really interesting, nausea and vomiting, something we maybe don't pay as much attention to as we should, and hopefully you will give us some enlightenment on nausea and vomiting. We look forward to hearing you. So I'm now going to hand it over to you.
Thanks, Dr. VG. I just want to confirm that everyone can see my slides.
Well, I can.
Yes, I can.
Thank you so much. So yes, good evening to all my other colleagues. I see a few of us are trickling in. I know it's quite a lot after our last weekend, a very successful weekend at that. But tonight I'm just going to give us a quick approach to nausea and vomiting, and also pay specific attention to one of the more important functional disorders or motility disorders in gastroparesis, and then a couple of slides on some of the other maybe not so well-known disorders. Okay, and that's the outline of my talk. So just to start off with, I think it's very important to have clear definitions of what we're talking about. So for today, I'll be discussing nausea and vomiting. But as you can see, there are many other symptoms as well as syndromes that can either overlap or actually be completely different. And when you ask a patient, they may be describing one thing, but they actually mean another thing. So it's very clear then it's very important then rather from our side to be very clear on what we are talking about. So nausea, we all know, is the sensation. Usually it's a vague sensation around the abdomen that is associated with a few other systemic symptoms, such as tachycardia, such as sweating, hypersalivation, and most often nausea is actually accompanied by vomiting. And vomiting is a very complex, I'd probably call it a reflex, that's associated with a forceful expulsion of gastric contents. And this is a complex interplay between the nerves and muscles. You get abdominal contraction, you get respiratory contraction, you get opening of your esophageal sphincters, as well as closing of your glottis, as well as your small palate, thus allowing the food or contents from the stomach to be extruded outwards. This is also similar to retching. Retching is also this forceful movements of the abdominal muscles and the respiratory muscles. However, the big difference between retching and vomiting is that with vomiting, you have an expulsion of the food or the contents, whereas with retching, you don't. This must be, differentiated from regurgitation, which is another common symptom, but is not exactly the same, or in fact, it's not the same at all as with vomiting. And regurgitation is the effortless reflux of contents either from the stomach into the esophagus or from the esophagus into the oropharynx. Thereafter, you can get mastication and then re-swallowing, or you can get expulsion of that vomitus, or rather that contents. And this is associated with the rumination syndrome, which I will get into a little bit later. Dyspepsia, it's another symptom complex, which has its own differentials. We do know that within the world of functional GI disorders, it is associated with your two main subtypes, namely your epigastric pain syndrome. So this is epigastric fullness, epigastric burning or pain sensation, as well as your postprandial distress syndrome. So this is a feeling of postprandial fullness, as well as early satiety. So all of these kind of must be differentiated when we are talking about patients, or when we're talking about nausea and vomiting, but importantly, when we are speaking to our patients and trying to get a history. In terms of the pathophysiology, particularly of nausea and vomiting, central to all of this really is the medulla, is the vomiting center within the medulla. And there are many inputs to this, as is demonstrated by this graphic. You have some higher inputs coming from the optic centers, the olfactory center. You also have some inputs coming from the abdomen, and either via your vagal nerve, your vagal afferents, or your sympathetic afferents, or which travel via the vagus nerve or the spinal cord to use your vomiting centers and subsequently stimulating or indeed inhibiting the vomiting reflex. They are also, just of note, some of these afferents also come from outside of the abdomen, just to emphasize. You have some in the heart and around the heart, and you also have some in other organs, such as the testes, for example. So all of these, through various inputs, can then stimulate this vomiting reflex. There's also an important zone, the chemoreceptor trigger zone, which is on the floor of the fourth ventricle in the area post-rema. And this also has inputs both from the central nervous system as well as from the peripheral nervous system, and is mediated by many neuroreceptors, neurotransmitters rather, and through the main receptors being your dopaminergic and your serotonin receptors, and they can also then lead to nausea and vomiting. And this table just summarizes a little bit a few of those mechanisms. You can see in the first column is your anatomic sites. The second column is your various clinical stimuli, whether they be infectious, inflammatory, or indeed medications. And then through various mechanisms, various neurotransmitters and activation of receptors, you can then get nausea and vomiting. Obviously, when you know these mechanisms, you can then try and treat, at least your specific treatments can be more targeted or personalized. When it comes to the differential diagnosis, this is quite vast. As you can see, this table is actually cut off but there are many, many causes of nausea and vomiting. I'll just highlight but a few. As you can see in the medications and toxic etiologies column, we all know well, at least, that your chemotherapeutic medications and some of your other drug classes are strongly associated with nausea and vomiting. I just like to emphasize, and for us, those of us who are budding, soon to be hopefully gastroenterologists, medications such as your 5-aminosalicylates, as well as your thiopurines, which are used for your GI disorders, we know in IBD or maybe some other disorders, as you know, you may be using them to treat one certain symptom complex, be diarrhea, abdominal pain, and then as a consequence or as a side effect of these medications, you can then get nausea and vomiting. So I found that quite interesting. If you look at some of, intuitively, obviously we know that in the gastrointestinal system, all the way from the mouth up until the rectum and the anus, and all the luminal contents, as well as your adjunct organisms, pretty much any disorder with these organs can lead to nausea and vomiting through those sensory as well as those vagus nerve afferents that I discussed in the previous slide. I will touch on some of the functional disorders, and particularly since we're doing stomach, I'll speak quite a bit on gastroparesis, but just note that there are other causes. And then, of course, the other big group of causes is your neurological or neurogenic causes of nausea and vomiting. Of course, similarly, any kind of pathology that leads to a raised intracranial pressure can put direct pressure on your vomiting center in the brainstem, or stimulate various neuroreceptors and subsequent nausea and vomiting. And then, of course, finally, your endocrinologic as well as your metabolic diseases. Just to note, pregnancy is a common cause of vomiting. So it's just important to bear this in mind, particularly in the patients of childbearing age or female patients of childbearing age whom are sexually active. Of course, remember all the other metabolic conditions that are associated with nausea and vomiting too. So now when we come to a clinical approach to nausea and vomiting, acute vomiting is relatively common, we all know. And for the most part, it has benign causes, and it's mostly self-limiting and really doesn't cause many issues. Of course, when we do have, let's say, hemodynamic instability, when we do have metabolic or electrolyte abnormalities, this will then obviously warrant further workup. But the scope of this talk will be mainly on chronic vomiting. And by definition, this is vomiting that is persistent for more than 30 days. As I mentioned in my definitions slide, one must clearly define and differentiate vomiting from all the other syndromes and symptoms. And when it comes to the clinical approach, really the two main objectives are to identify some of the signs and symptoms that point towards a specific cause, and then also to try and pick up some of the complications or consequences and then manage them appropriately. With regards to the general management, fluid and electrolyte replacement in the acute setting is important, and it will happen across the board. And in some cases where there is malnutrition, we may need to have nutritional support. And of course, there is symptomatic therapy as well in the way of pro-motility agents, pro-kinetics, and as well as antiemetics. So this algorithm I got thanks to Dr. VG. It was a nice topical review a few years ago, which kind of really does summarize all those causes quite nicely and groups them very succinctly. And as you can see, this algorithm is quite nice that depending on what your index of suspicion is, you'll go down a specific route with regards to the workup. So for example, your central or your neurogenic causes, you'd consider in a patient who has perhaps a headache or some neurological symptoms, focal neurology, signs of raised intracranial pressure, such as papilledema. In this case, then the appropriate initial management or the initial workup will be a CT or an MRI scan. When we look at your endocrinopathies, as mentioned, pregnancy, it must be considered as it's really common and associated with some of those, your hyperemesis gravidarum syndrome. but also remember some of the other endocrinopathies, screening for thyroid disease. I think the TSH would be more appropriate for screening, but also remember diabetes, which I'll touch on a little bit later. Of course, iatrogenic causes, post-op nausea and vomiting. In this instance, we must obviously rule out obstruction, but of course, or mechanical bowel obstruction, but also a pseudo-obstruction, whether it's post-op ileus or acute colonic pseudo-obstruction. Again, I won't go into some of these. I'm sure we'll pick them up as we go further down the GIT, but just bear that in mind that they can also be causes and must be considered. And then when it comes to the mucosa, you can have obstructive lesions within the luminal tract or indeed mucosal lesions. And then the appropriate management here will be either endoscopy or radiography or cross-sectional imaging. Of course, there is also a role for your contrast swallows as indicated. So once you've done your first step, often or sometimes then they may not yield a diagnosis. The second kind of tier of workup will be geared towards your motility disorders as well as your functional disorders. And here you can do further evaluation. Like, I don't know if you can see my pointer, but halfway down, you can use your gastric emptying studies. You can use your gastric electrogastrograph, or as well as a manometry studies to kind of characterize these patients. And of course, once you don't have a cause, we then classify these patients in your functional group. Now, when it comes to therapeutic management, for most classes or most causes, your antiemetics and your prokinetics remain the first line or are the first line for treatment of patients. So I said today I'd focus mainly on gastroparesis. I think this is an important syndrome. And really the definition relies on three kind of cardinal tenets. The first is having signs and symptoms of gastric obstruction, if I can put it that way. And these are the nausea and vomiting, classically. Importantly, there's an absence of mechanical obstruction. And the third part of the diagnosis of gastroparesis is to objectively define delayed gastric emptying. When it comes to the etiology, just about 30% of patients, most of the secondary causes of gastroparesis are related to diabetes. And the typical patient here is a type 1 diabetic who's had dysglycemia for more than 10 years and autonomic dysfunction. If this patient has, nausea and vomiting, one must consider this diagnosis. The next most common cause is your post-surgical gastroparesis. Pretty much any abdominal surgical procedure can lead to gastroparesis through various mechanisms, your anti-reflux therapy, your bariatric surgeries, as well as your surgeries that involve the vagotomy or vagal nerve ligation. Of course, other surgeries outside of the gastrointestinal tract, head and neck, cardiothoracic surgery can also be associated with injury or of the vagus nerve and subsequent delayed gastric emptying. Just remember if you have a typical patient with acute onset with a preceding viral prodrome, consider viral gastroparesis. This actually confers a better prognosis compared to some of the other causes. Endocrine can also cause neurologic disorders, and in fact, even other miscellaneous things can also be associated with paraneoplastic phenomena. Unfortunately, though, the vast majority of gastroparetics are idiopathic. There's no cause that has been found, or that is found rather. In terms of the symptomatology, the cardinal symptoms for gastroparesis are nausea and vomiting. But as I mentioned, sometimes you can have overlap, and certainly your dyspeptic symptoms, particularly when gastroparesis is associated with your functional dyspepsia. These can also be involved. However, they do not predominate. The vomiting should be the predominating symptom. When it comes to the pathogenesis or pathophysiology of gastroparesis, most of the studies have been done in patients with diabetic gastroparesis, and and on the basis of autonomic, sensory, as well as motor neuropathy. And this really leads to many of these pathogenic mechanisms, such as decreased accommodation, as well as visceral hypersensitivity. Importantly, however, there's also a loss of the intestinal cells of Kegel. As I think we remember from Barbara's talk, these are the so-called pacemakers of the stomach. And so a dysfunction here then can also lead to delayed gastric emptying. And of course, then I did mention that when you have then loss of the nerves or vagal stimulation, this can also then lead to delayed gastric emptying. The diagnosis the tenet of the diagnosis of gastroparesis is to rule out mechanical obstruction. So I haven't shown that here, but obviously, endoscopy would be paramount prior to considering a diagnosis of gastroparesis. However, when it comes to the specific diagnosis, the gold standard is gastric scintigraphy. And particularly a solid phase gastric scintigraphy. This is then diagnostic of delayed gastric emptying when there's more than 10% of retention after 4 hours. This is on the basis that for the controls or normal individuals, by 4 hours, the stomach should be completely empty. The two other mechanisms or two other modalities rather of confirming the diagnosis, or rather of showing delayed gastric emptying, are your wireless motility capsule. It can look at quite a few other things, but of course, what's important to us is a gastric residence time. And I believe diagnostic or comparative to the scintigraphy is a gastric residence time at 5 hours. And then, of course, the C13 breath testing. We know here you have your substrate that's labeled with C13, and then it should have a nice plateau as the meal leaves the stomach. However, if this does not happen, this is indicative of gastroparesis or delayed gastric emptying. Interestingly, these two other modalities can be used conversely to show rapid gastric time, such as your dumping syndromes and such. So this image just shows a gastric emptying study. As you can see on this cartoon in the top left image, that is directly after the meal. And as you can see at various times, so the stomach empties and empties. And by 4 hours, it's completely empty. So this is a negative study. Just of note, you might see some reading with liquid studies. You may also see using certain cutoffs with a shorter time frame, so like 2 hours or 100 or shorter, even 90 minutes. However, these have not been shown really to correlate on large scale studies. And when it comes to the liquid gastric emptying study, there may be an unacceptable amount of false negatives. So just bear that in mind if you come across this. When it comes to the medical management, so with all the syndromes that we'll discuss today, fluid resuscitation or fluid replacement, electrolyte abnormality correction, as well as in some instances, nutritional support will be a basis. But when it comes to gastroparesis, specific therapies or is the first stage would be dietary advice. And we'd advise our patients to have a low-fat, low-residue diet. Obviously, we'll do this in conjunction or in consultation with our dietetic colleagues. The rationale for low-fat, fat by itself, or high-fat or fat itself, rather, slows gastric emptying. And this is through that GLP incretin effect, that system, neurohormonal system. And then in terms of your fiber, particularly your your insoluble fibers, as mentioned before, gastroparesis can be associated with some of these other functional disorders. So it can worsen bloating, it can worsen abdominal pain and distension. So that's why this would be the appropriate dietary advice for these patients. In terms of feeding, we all know that oral feeding is always best. However, in some instances, particularly in patients who've had rapid weight loss in a short amount of time, we may then elect to assist with enteral alimentation, which I'll discuss maybe in a couple of slides. Glycemic control is obviously very, very important, particularly in diabetic gastroparesis. that dysglycemia itself is central to a lot of the pathogenesis. I just found interesting, though, in some experimental studies, dysglycemia or hyperglycemia, even in the absence of diabetes or a diagnosis of diabetes, in itself causes delayed gastric emptying. So clearly, this is a very important, important thing to look at when we're dealing with such patients. And then I did mention pharmacotherapy, general management. Your prokinetics are the first line management or medical management in gastroparesis. Metoclopramide works quite well. However, one should be wary when using it for a long time, particularly more than 12 weeks. It's associated with significant adverse effects, particularly your extrapyramidal side effects. And I believe the most severe is tardive dyskinesia. Domperidone is a D2 antagonist. This probably has a better side effect profile. I'm not sure the availability, if it is quite as readily available as metoclopramide, but it does have a better side effect profile. Just of note, there is issues with the QT prolongation, particularly if you have other medications that can cause QT prolongation. And also it can cause hyperprolactinemia and unwanted lactation. When it comes to the endoscopic and the surgical management, I believe that the biggest body of evidence comes from gastric electrical stimulation. So this is the so-called gastric pacemaker. And then this has been validated in diabetic gastroparetics as well as idiopathic group, and not quite as strong in this group. However, it has been recommended by various guideline statements. When it comes to intrapyloric Botox injection, this has been studied quite extensively and has been found quite useful, particularly in the phenotype of functional pylorospasm. And I think I do have a picture on the next slide. But this specific phenotype really does confer a poorer prognosis. But this treatment modality has been described in such patients, although not for the broader patients with gastroparesis. Your other endoscopic modalities, really the goals here are either to decompress the stomach, so that would be your venting gastroscopy, which is a percutaneous endoscopic gastrostomy with a vent that then can allow you to remove some of the gastric content. Or you can actually use it then to feed the patient. But then obviously one must know that if you are getting to this point, you have to consider that there's this delayed gastric emptying, and so you have to do post-pyloric feeding. So if you are going to do a peg feeding, you'd have to have a jejunal extension or proceed directly to a percutaneous endoscopic jejunostomy. There are other endoscopic modalities, your pyloroplasty, which you can use, as well as stent placement. These again have value, particularly in this pylospasm phenotype that's more severe. However, there are no large-scale studies. What has shown quite a lot of promise is gastric peroral endoscopic myotomy. It's pretty similar to the GPOM that we use for type 3 achalasia. And this may be something, I'm not quite sure if this is available widely, but obviously if there is expertise, then this could be a modality that would offer good benefit. Of course, when you do have refractory cases, we have to then speak to our surgical colleagues, and there is a modality called cervical pyloroplasty, or indeed even gastrectomy, but these are a kind of salvage modalities, salvage therapies. So these two images, if you can cast your eye to the right most image, this is the so-called endoflip, or functional lumen imaging probe. I think we have seen it in the esophageal realm, but it is also used in the gastric realm, particularly in gastroparesis. And so this, unlike your manometry, which measures your pressure, this measures a capacitance. And so as you can see, it's demonstrated that there is, let's say, constriction around the pylorus. This then can help you identify these cases. And as you can see then in your middle image, this is pneumatic dilatation, which has been attempted for such patients. There are some other adjunctive therapies. Acupuncture has been shown useful for symptoms. However, it doesn't decrease or increase gastric emptying. There is also a pressure point, I believe it's on the wrist, that does help with symptoms, some various herbal remedies, as well as some other remedies that are used in the functional GI world. And there is value for these as well for augmentation of symptom control. So I'll move on to some of the other functional syndromes. These two, or by definition, your functional GI syndromes are disorders of the gut-brain interaction. And importantly, there's no organic cause for these disorders. So when it comes to nausea and vomiting, there are two main syndromes, the chronic nausea vomiting syndrome, as well as your cyclic vomiting syndrome. These two are rare. They've been described in about 2% of the population, particularly younger patients, as well as patients who have overlapping irritable bowel syndrome. Importantly, as compared or to differentiate rather from gastroparesis, these syndromes, you do not have delayed gastric emptying. And as you can see, as with all our functional bowel syndromes, you do have your Rome 4 criteria, which I won't go into. However, you can see that your cyclic vomiting syndrome has been described as a so-called abdominal migraine and associated with migraines, as well as the prodrome of migraines then preceding these vomiting episodes in the absence of migraine. So insofar as specific treatment is concerned, triptans then offer a therapeutic modality for the treatment in this case, and these cases specifically. When it comes to, there's also another subtype of cyclical vomiting syndrome. This is the cannabinoid hyperemesis syndrome, and this must be considered in patients as well. I'm sure often patients would voluntarily disclose that they use cannabis. So one must then just have this index of suspicion and ask the right questions. And just a clue in terms of the management, a clue in terms of the diagnosis is that these patients can get improvement in their symptoms when they get into hot baths, when they have these vomiting attacks. And obviously it's important to make this diagnosis because then the therapy is just cessation of cannabis and then their symptoms as well as, well, they can improve. Then I would like to also discuss the rumination syndrome. I know that Dr. Vici and I did discuss this a little bit on Saturday, so I'll just fly right through. I think the important differentiator here compared to all the other things I've discussed this evening is that the cardinal symptom in this instance is regurgitation. And as I mentioned, regurgitation is that effortless, it can be voluntary, but the regurgitation of or reflux of food, as opposed to that forceful reflex that is vomiting. It has been associated, or the risk factors are young children, more than adolescents and more than adults. Sorry, I had that in the wrong order, as well as some of your other functional rheumatological disorders such as fibromyalgia. In terms of the pathophysiology, it is hypothesized that there's an increased intra-abdominal pressure together with the decreased intrathoracic pressure leads to this gastro or reverse gastroduodenal gastroesophageal gradient and subsequent reflux of these contents. As with all our functional disorders, it has Rome 4 criteria, which you guys can familiarize yourselves with. But there are other modalities that you can use to work up these patients. And so these three pictures demonstrate, so figure A demonstrates an anteroduodenal manometry, conventional manometry. And the sign here that's been demonstrated are these tall R waves that occur through all of the leads simultaneously. And this is indicative of regurgitation events. In B, I think we're more familiar with this, which is your high resonance manometry. So high resonance manometry. In this case, the purple columns with the yellow stars, these are showing your regurgitation events as well. And then finally, in C, image C, this is an electromyogram or myograph. And this then shows, the electrical activity in your abdominal muscles, your intercostals. But as you can see that there's a flat line in your diaphragm. So all of these are diagnostic for, or at least they are telling you that you're having regurgitation events. When it comes to the management, if you can just cast your eye on this algorithm, importantly, as with everything that I'm going to emphasize over and over again tonight, clearly define whether it's vomiting or whether it's regurgitation. If it's vomiting, there are various other things to rule out, gastroparesis being one, take a history about certain medications, and then inquire about other CNS disorders. If it is regurgitation, which is then typical of this syndrome, then you're guided towards ruling out your differential diagnoses, particularly gastroesophageal reflux disease and achalasia. And then once your diagnosis is made, of course, it's a biopsychosocial approach. And then specific therapy is a diaphragmatic breathing. Again, I think Dr. Viji did describe to us how one would perform this. Just to add, the efficacy of diaphragmatic breathing is increased by biofeedback. And so biofeedback is when you'd have the patient doing this diaphragmatic breathing connected to an EMG machine, and then being able to see the regurgitation events, and then being able to suppress it. And apparently that has more durable effect than just the diaphragmatic breathing by itself. In medical modalities, we know that baclofen can increase the tone of the lower esophageal sphincter. So this can be used, as well as your D2 antagonists. And then, of course, we know in refractory cases, we may have to consider surgical management or endoscopic fund application. And I want to just change lanes a little bit to the realm of the feeding or eating disorders, and particularly bulimia nervosa. So we all know this is a neuropsychiatric diagnosis. It has one specific DSM-4, or indeed now new DSM-5 criteria. And the cardinal features here are binge eating. Now, a binge eating episode is when you have excessive eating of a large meal over a short amount of time. And then associated with this is a sense of a loss of control during this episode. The other cardinal feature is compensatory behaviors to either reduce weight or to avoid weight gain. And such behaviors are purging episodes. So in the context of this talk, it would be things like self-induced vomiting. But remember, these patients can also use laxatives or diarrhea, diuretics or enemas. And just to complete the criteria, it must happen at least once a week for at least 3 months. And then importantly, it must also then not happen concurrently with a diagnosis of anorexia. Just in terms of like the workup, or when you're considering bulimia in a patient, it's important to have a high index of suspicion. It's important to take a good history, not only a medical history, but also a neuropsychiatric history, as it is associated with other mood and personality disorders. In terms of the clinical signs, as you can see in the picture, this shows a poor dentition or dental caries. This can be a sign that someone is having self-induced vomiting. And obviously, the acid and the gastric contents can then ruin the tooth enamel and then and result in poor dentition. Just another clue for patients who might have this diagnosis. You might have patients who have excessive exercise, and particularly patients who are exercising despite having injury, or just dieting despite having injury or illness. So these are patients that also might have, in the right clinical context, might have a diagnosis of bulimia. Another interesting thing that I found in my reading was there are other methods of purging, particularly if you think about your celiac patients. They can intentionally have a gluten diet to induce diarrhea or to induce vomiting, and subsequently avoid weight gain, as well as your diabetics. Those who are insulin requiring can reduce their insulin so that they avoid excessive weight gain. So just bear that in mind in these patients. And then, of course, I've mentioned the dental caries. but one must also know some of the other effects associated with purging. Depending on what drugs the patient might be taking, you need to explore that there might be cardiac, neurological, or renal complications. So that's something to bear in mind. And of course, the management, multidisciplinary team with our psychology and our psychiatry colleagues. So I'll just fly quickly through medications. We know that chemotherapy is well described as causing nausea and vomiting. The two syndromes, well, I think they're synonymous, whether it's a post-chemo nausea vomiting syndrome or chemo-induced nausea and vomiting syndrome. There are various phenotypical subtypes, but what I found quite interesting was that there are various risk factors for this disorder, as I've listed there. And importantly, certain chemotherapeutic agents have different emetogenic properties. So as you can see on this table, far on the right side, these agents are most strongly associated with nausea and vomiting. And as you go towards the left, they're less associated. Importantly, remember that radiation therapy, although it has its own issues in the gastrointestinal tract, radiation, gastroenteritis, colitis, enteritis, etc., radiation is a chemosensitizer. So patients who are getting radiation therapy may be overly sensitized to chemotherapy. And so when it comes to the management, I think our medical oncology colleagues are quite well versed. Depending on the risk, based on whatever chemotherapeutic mechanism the chemotherapeutic medication they'll be prescribing, there are various regimens of pre-chemo antiemetics as well as post-chemo antiemetics. So one can just read about that at your guys' leisure. I was going to get this a little bit interactive, but because of this last weekend and some of us writing exams, I'll just push straight through. If you can just see the image, the chest radiograph on the left, you can see there's a small slither. You know, if there's, this I'll get to the condition later. But if you look at the CT scan, you can see that there's air in the mediastinum, and there's also a little bit of air in the pleural cavity. So this is one of the big complications of vomiting, and this is a Bulimia syndrome. So just to remind you, there are some complications that we must be aware of, based on the emetic injuries that happen to the stomach, the esophagus, and indeed even the oropharynx, as I've mentioned earlier. The esophagus, you can have all various ranges of esophagitis. In terms of the mucosal tears, I've mentioned Bulimia syndrome in my last slide. This is obviously a medical emergency. You have a patient with subcut emphysema after a vomiting episode. You have features of mediastinitis. This is an emergency. We need to speak to our surgical colleagues to get that repaired. So the difference between Bulimia, which is a transmural tear, and Mallory-Weiss tear is that the Mallory-Weiss is a mucosal tear. So these patients may have, I think we've seen a couple, may have a little bit of upper GI bleed after following a vomiting episode. Most of them are self-limiting. However, in severe cases, at endoscopy, we can have hemostatic measures such as clips. Just to remember some of the other complications, we can have spasm of the glottis with its associated issues. Aspiration, you can have an acute aspiration pneumonitis. Recurrent aspiration episodes can then lead to chronic lung disease, to fibrocavitary bronchiectasis, etc. So just bear that in mind when considering some of the complications. And of course, fluid and electrolyte abnormalities, I think, is self-explanatory. So in summary, we know that nausea and vomiting is a very common GI symptom. As you've seen, there's a vast differential, and I haven't even gone through the half of them. Just be aware of the different definitions, whether it's vomiting, whether it's regurgitation, and that would allow you to get an approach or differential based on that, and just have a high index of suspicion again of these other functional disorders that we don't see that common. And finally, beware the complications. So these are my references. And at this point, I'd like to just acknowledge Dr. Vijay Naidu for his help with the content. And yeah, I'd like to then invite you guys for a couple of comments or questions.
Thank you, Mzamo. Mzamo, that was excellent. I think this isn't an easy, like in a topic, nausea and vomiting. It's extremely like wide. The way I sort of viewed it is, in which situations are these patients referred to us as subspecialists? So now, obviously, usually by the time the patient arrives to us, it's more than likely people have excluded the usual etiologies, right? However, having said all of that there, you will be quite surprised that something as simple as pregnancy can often be overlooked, especially if it's a unplanned one in a very young female. And this comes as a surprise when you suddenly ask, but has anyone checked if you are pregnant? Sure. And when was your last menstruation? It's actually happened to me a few times when a patient was actually referred for unexplained nausea and vomiting. So I think while we are often referred most of these patients after we assume extensively worked up, we need to still be aware that the common things occur, commonly. And you have to go back and revisit that the obvious things haven't been excluded. The other one that is often overlooked is the use of marijuana. Okay, people don't often think about it. It isn't information that like in a patient of volunteers, unless you specifically actually ask. Okay, things like the endoflip and antroduodenal anometry are there. There's plenty of small articles on it that have been written. I think it's very important that all of you are aware of it, but I'm not quite sure how many of our centers are actually able to do endoflip and antroduodenal anometry. Do you have any idea, Mzamo, after speaking to all the fellows over the weekend?
No, certainly not. I know at our center, we don't have access to these just yet. I'm not quite sure within our context. I suppose we can ask people in the group, but I'm not aware that we have access to these.
No, I don't know if anyone else in the group wants to volunteer the information. I mean, things like the endoflip is quite extensive. So, and you're only going to probably, and it's a very niche thing. So it's only going to be used a few times a year. So you have to ask yourself, I'm going to buy this really expensive piece of equipment, and how often is it actually going to be utilized? And I think that's a problem all over the world. Yes, there is a role for it in maybe very highly specialized referral centers. But even here in South Africa, I'd be struggling to see how many patients we would actually say need to have an endoflip, and we're going to do all kinds of endoscopic iotomies. So I think if you're at a center that's doing large numbers of endoscopic iotomies, both for achalasia and for gastroparesis, then it may be something to consider. Okay, so does anyone in the audience have any questions for Mzamo, or any comments? Let's have a look at the chat.
VG, I won't mind commenting, but I'll wait to see if the other fellows have any questions or comments.
Sure, I'm just looking at the chat. The other thing I've also entered on the chat is I've just put in a reference there on a recent review article If you're able to access it through your institution, it may be worthwhile to have a look at it on chronic nausea and vomiting. Asheko, I can't see any other questions, so the floor is yours.
I think everybody is understandably exhausted. But no. I think, Mzamo, you did an excellent job, as BG says, of a really broad topic. But I think you highlighted the really important stuff that we just need to not forget. And as he says, by the time the patient comes, most of the sort of usual suspects are excluded. It's just to remind you that a Zenker's diverticulum typically presents with dysphagia, and you might even see a mass in the neck, but sometimes patients might have regurgitation and also halitosis. And then also with your patients who've got bulimia, apart from the dental condition, they also may have halitosis, and the way they try to mask the halitosis is that they chew inordinate amounts of gum. Which of course fortuitously might give them diarrhea, or osmotic diarrhea mechanism because of the sweetness in the gum, which of course they're also trying to do because they don't want to gain weight, as you've rightly pointed out. So it could be just a vicious cycle of a bulimic who chews a lot of gum, also has diarrhea, but is also having nausea and vomiting. So it's quite it can be quite a vicious cycle. I thoroughly enjoyed your chest X-ray and CT on the Bulimia syndrome. I think I traumatized Tanya with that question in our mock preparations. So I was quite happy to see that. But really, that's all I have to say. I think, good luck to all of you guys that are writing tomorrow. I think you'll be fine. I guess it's normal to feel a bit of anxiety, but I think you're all ready, and I really can't foresee that there'll be any problems. So all the best. Rest well tonight. I don't think there's any more that any of you can do. And yeah, we'll see you next time as colleagues. Viji, thanks for the session. I thought it was excellent. And thanks to everybody for attending. As I said, it was really an oversight on my part not to cancel the session. And I really, really feel badly about it. But I think we had a great session. Thanks, Mzamo. Thanks, Viji.
Thank you all. Thank you.
Thanks, guys. I think I also want to actually echo Mashiko's sentiments, and all the best for the exams tomorrow. Having said that, I think I don't want to ask anything further that might stress anyone out. So I'm going to stop here now, right? Okay,
thank you.
All I need to do is say thanks to the presenter, Mzamo, excellent, well done. Thanks to Echo UNM and Echo from India, the Echo India team for all their support. And remember, there's a feedback form that is available in the chat. Please fill it in, and recordings will be available on the Gastro Foundation website. And I'd like to thank the Gastro Foundation as well. And again, thanks to all the presenters. Please fill in the form, and good luck and good night to all. Thanks, guys.
Thanks all. Good night.
Good night. Good night. Good luck. Where is this one?